Welcome. In this explainer, we're diving deep into the world of infectious colitis. We're going to explore the bacteria, the viruses, and the parasites responsible, and really break down the clinical strategies we use to identify them and, of course, to fight them. Here's our game plan. We'll start with how a patient presents. Then we'll get into the nitty-gritty of identifying the specific invader. We'll meet the usual suspects in our rogues gallery of pathogens and talk through the very specific treatments. We'll finish up by looking at the bigger picture, prevention and public health, and some really crucial complications you need to be aware of. Okay, so first things first. Before we can effectively tackle this condition, we have to start with a clear and precise clinical definition. What exactly are we talking about? This definition is our clinical anchor. It sets the baseline for symptoms, but honestly, the key detail here is the time frame. That 14-day cutoff for an acute case, that's a major fork in the road. It pretty much dictates our entire diagnostic and therapeutic strategy from that point on. At the bedside, this is one of the very first, most fundamental distinctions to make. Is there visible blood? It seems like a simple question, but it's an incredibly powerful diagnostic clue. It immediately starts to narrow the field of potential culprits, pointing us toward very different classes of microbial invaders. So, with a clinical picture starting to form, the next big challenge is identification. How do we get from a simple stool sample to a definitive diagnosis of the causative agent? You know, what's really interesting here is that this isn't a brute force test for everything approach. It's a really sophisticated, tiered strategy. You start with the most common culprits to get answers quickly and efficiently. It's only when that initial screen comes up empty that you escalate to more advanced molecular methods. This whole workflow is a perfect balance of diagnostic certainty and just smart resource stewardship. Okay, so we've established our diagnostic framework. Now, let's meet the pathogens themselves. Understanding the unique profile of each one is absolutely key to predicting the course of the disease and, more importantly, choosing the right response. This table really highlights the distinct personalities of these bacteria. Take Shigella, for instance. Its extremely low infectious dose, we're talking as few as 100 bacteria, explains why it's so easily transmissible. Then you've got STEC, where the absence of fever is a classic, if a bit counterintuitive, clue. These details aren't just academic trivia. They directly inform your clinical suspicion and your entire management plan. But bacteria aren't the whole story, of course. Viruses like norovirus are notorious for causing these explosive outbreaks, and they do it by temporarily impairing the intestinal barrier. And then you have parasites like Giardia, which present a completely different kind of challenge, often causing these chronic malabsorptive syndromes that can have serious long-term consequences. Identifying the pathogen is a critical victory, no doubt, but it's only half the battle. Now we have to select the right therapeutic countermeasure. The crucial point here is that antimicrobial therapy for colitis has to be a precision strike, not a blanket bombing. The choice of drug, the dose, the duration, it's all highly specific to the pathogen. A best guess approach can be ineffective or even worse, harmful. And I have to say it again, for all of these cases, aggressive rehydration remains the absolute cornerstone of supportive care. Okay, this is one of the single most critical takeaways for managing colitis. With any suspicion of a Shiga toxin-producing E. coli infection, antibiotics are strictly, and I mean strictly, contraindicated. The data is clear. Giving them can actually increase toxin release and trigger the catastrophic complication known as HUS. This is one of those cases where the correct action is in fact inaction. Supportive care only. Now, the pediatric population. That requires a whole other layer of clinical vigilance. The risk of HUS from STEC is much, much higher in young children. And an infection like Giardia isn't just an inconvenience. It can actively stunt a child's growth. This elevated risk, combined with the restrictions we have on certain antibiotics in kids, makes pediatric colitis a truly specialized challenge. So let's zoom out from the individual patient for a moment and look at the community. How do we prevent these infections? And how do we control outbreaks when they happen? This really highlights the essential link between what happens in the clinic and what happens in the community. Certain pathogens, like Vibrio cholera, are notifiable diseases that trigger an immediate public health alert. The same goes for institutional outbreaks of C. diff or Giardia. All of these measures are designed to do one core thing: interrupt the fecal-oral route of transmission and stop a single case from becoming a widespread crisis. And, on a lighter note, a little microbiology humor. It seems that even at a microscopic level, professional relationships can be, well, complicated. All right, finally, let's address the potential long-term consequences of these infections and just take a moment to review and consolidate what we've learned. This isn't just about a few days of discomfort. The potential long-term consequences, or sequelae, can be severe and are very pathogen-specific. We're talking about everything from the acute renal failure of HUS to the neurologic paralysis of Guillain-Barré syndrome. These potential complications show exactly why accurate diagnosis and timely, appropriate management are so incredibly critical. Okay, let's apply this. Here's a clinical scenario. A 4-year-old child comes in with 15 days of foul-smelling, fatty diarrhea and cramps, no travel history. Considering the duration and the specific character of the symptoms, which pathogen is jumping to the top of your list? The answer is Giardia lamblia. The key clues here are the chronicity. It's pushing past that 14-day acute window and those hallmark signs of malabsorption. This combination points directly away from your typical acute bacterial or viral causes and squarely toward this common parasite. Now for a critical management decision. An adult patient has an acute onset of bloody diarrhea and severe cramps, but they're afebrile, meaning no fever. What management step must be absolutely avoided if you suspect STC? That's exactly right, the administration of antibiotics. This is a crucial do-no-harm principle in action. Giving antibiotics in this specific setting can trigger the cascade that leads to Hemolytic Uremic Syndrome. The only proper course is supportive care and very vigilant monitoring. And we'll conclude with this forward-looking question. The pathogens we've discussed are not static targets. They're constantly evolving, and antimicrobial resistance is a growing threat. This reality demands that our diagnostics, our therapies, and our public health surveillance must also evolve continuously just to stay one step ahead. Thank you for joining this explainer.